A very warm welcome, everyone. So this is our third meeting of the Health and Adult Services Standing Scrutiny Panel of this civic year. Just to remind everyone that this meeting is being held in a hybrid form, with some members and officers joining the meeting online and other colleagues being present in the room. The meeting is also being live streamed on YouTube. Can I just remind anyone that's online to be on mute and to use the raise hand icon if they wish to speak. I understand at the moment we just have Councillor Alexander joining online, although I am expecting Councillor Raza, who has just popped up as if by magic online too, which is excellent. And I think our Cabinet Member for Healthy Equal Lives will also be joining the meeting online this evening as well. So if we move on to the first item of business this evening, it's apologies for absence. I have received apologies for absence from Councillor Conti, who is being substituted by Councillor Young. Thanks, Councillor Young, and welcome. I've received apologies from Councillor Tai and also from Kerry Stevens, our Strategic Director for Adult Social Care. The adult social care team are being represented this evening by Stuart, who is the Assistant Director for Adult Social Care Operations, Sophie, who is the Assistant Director for Assurance and Governance, and Avtar, who is the Head of Service Integrated Commissioning. That just rolls off the tongue. You are all very welcome. We also have our health partners as usual, which we're very fortunate to have. Neha, our place-based director for Ealing NHS North West London, Dr. Taylor, our Borough Medical Director for Ealing from North West London, and I'm not sure if, I don't think Chris Hilton is joining us this evening. So if we move on to item 2, urgent matters, I've received no urgent matters for discussion at this evening's meeting, which brings us on to our declarations of interest. I will start by declaring an interest in that I am employed by the Nursing and Midwifery Council. Does anyone else wish to declare an interest? Councillor Mataza.
Yes, I am a general practitioner in the Borough of Ealing.
Excellent, thank you very much. Any other expressions of interest from members? No, in which case we will move on to item 4, matters to be considered in private. There are no matters to be considered in private this evening, which brings us on to the minutes of the meeting held on the 9th of October. Is the panel content that these are a true and accurate record of the meeting? Agreed. Agreed, thank you. So we then move on to the panel work programme. You're asked to consider the draft outline work programme as it's currently tabled. Any questions or observations in relation to the work programme at all, or are we content with it? I'm not seeing any indications, so I will take that as we're content. Thank you very much. Which then takes us on to our first substantive item of the evening, changes to the health landscape. So I will invite Neha and Dr. Taylor to talk to this item. This is a brief update following your presentation in October. I do just want to inform the panel, as I think I did last time, that there may be questions that you ask where information is not currently available because the situation with changes to the landscape is evolving. Please do bear with us if that's the case. Neha and Dr. Taylor have undertaken to provide any subsequent information outside of the meeting if they're able to do so. So at this juncture, I'll hand over to you in the first instance, Neha.
Thank you very much, and good evening, everybody. So I won't put up the slides. There are only a handful of slides following my quite in-depth presentation at the last meeting. Just a few things to note. I should start by noting that Frances O'Callaghan, our Chief Executive, yesterday announced that she had chosen to take a national role as the Chief Exec of NHS Blood and Transport as of 1st of February. So she will be leaving at the end of January, but the board is absolutely committed in making sure that there is plans and interim plans in place and a new organisation is stood up with a new Chief Executive Officer. So since putting these slides in, there has been already development, and that's how fast-paced everything is happening, really. But that was an important piece of news. I think I wanted to make sure that was heard, because in this slide pack we talk about Frances O'Callaghan being the new Chief Executive Officer. She is at this present. Mike Bell is our new chair, and a new executive team has been stood up from partners following a successful recruitment process. And the interview process included a panel of external colleagues from regional NHS England team, including their inclusion team alongside Frances and Mike. The wider structure for the organisation, as you will also have heard, that the Treasury has now approved the process to continue with the redundancies needed in the ICB to enact the decision that was announced earlier in the year about the reduction in the ICB workforce again. And this will be done quite swiftly over the next few months. So, and we will do whatever we can to keep the scrutiny panel and the chair updated on progress to that. But in the meantime, work continues. The medium-term financial planning framework was released over the in October. It describes, it talks about the 3-year sort of plan over the next 3 years of what is required. Document builds on the 10-year plan and the 3 shifts that I talked about last time, with shift in more neighbourhood working and if into the community, digital and more preventative and proactive work rather than the reactive response. It talks about neighbourhood health teams, which I also went through in quite a lot of detail at the last meeting, about our thinking around neighbourhood health in the future. And as we develop more information, we will absolutely come back to this committee, or the relevant partners will. Talks about digital and population health, But it also talks about some of the key things that we need to do around waiting times and around primary care and improving primary care, which has been a regular item at this scrutiny committee for some time. And just finally, well, just before I talk about one last thing, we submitted our nomination for West London NHS Trust to become our integrator for the Ealing Place system. There was a mutual assurance meeting on the 30th of October. Actually, I think it was a really good demonstration of the whole partnership, really stepping up and talking with one voice about what we felt was needed in Ealing and how we wanted to work together as all provider partners in the local system and really integrate and think about how we deliver care better at more local levels. And we have submitted a business case for some non-recurrent monies just for this financial year to really help us with some of the thinking that we need to do with engagement and communication with our local populations, some of the organisational development work we need to do in terms of stepping up our neighbourhood leadership teams. And we're still waiting for the outcome of whether we'll receive that, but I'm hopeful that there will be funds eventually to help us to move to the next stage on this journey. And then the last thing, which isn't on the slides, but I wanted to also note is, yes, on Tuesday we got a communication that Jubilee Gardens Health Centre in Southall was nominated as one of the first public-private partnership, PPP, I think that's what that stands for, redevelopments to become a neighbourhood hub in Ealing. I think it's the only one in London, I believe. So I'm really, really pleased about that because I have been talking about needing good estate in Ealing for quite some time. So that hub would be redeveloped by 2030 and it would be there to serve the population of the North Southall neighbourhood that I've showed in my slides in the past. Thank you.
Thanks very much, Neha. It's safe to say a mixture in terms of the content of the report, and I'm sure I join with the whole committee when I say I hope those that are going through a redundancy process are being well supported throughout that by the ICB, because it's never an easy thing to go through for you and your colleagues. And I do think it's really promising news, the development in relation to Jubilee Gardens, so well done for all of your advocacy and work around that. So I will turn to my panel members for questions. Sorry, Dr. Taylor, did you just want to add?
Yeah, just wanted to add just a couple of things. Just wanted to say that, despite the uncertainty, the borough-based partnership, continues to forge ahead in terms of, neighbourhood health and how we can make sure that, that really becomes a reality, and having the news around the Jubilee Gardens being the only site in London. They've obviously been chosen around the country, but particularly for us in Ealing, that's really put Ealing on the map in terms of that proof of concept of how neighbourhood health can work in the future. So, we look forward to continue to work in terms of getting that really developed and embedded in terms of how we deliver services in the community. So.
That's excellent. Thanks very much. So I've got Goulet indicating. Any other panel members want to come in on this? I'll take you, Lorraine, afterwards. So Goulet first.
Thank you. I'd like to congratulate everybody on the nomination of Jubilee Garden Medical Centre. And as a carer, I have full confidence in that medical centre, and I know it has been run wonderfully well by all the people who are there. So I've got 3 questions to ask. The first question is, what governance and assurance mechanism will ensure that the borough level integrator does not unintentionally increase inequalities in access, digital inclusion, or waiting times for carers with lived experience and vulnerable residents? Second question, how will population health management data be combined with lived experience insight from carers? I've put Health Watch as well and co-production boards to drive planning and prioritization, particularly in deciding how the 200K non-recurrent investment is used? Question 3, how will carers and residents' voices be built into the new neighborhood health model from the start rather than other decisions have been made? That means that carers and residents to be involved from the very beginning of neighborhood health planning, not as consultees, but as co-designers of what good local care actually looks like. And will the integrator Northwest London NHS Trust commit to a formal engagement route with the carers board and co-production boards for all neighborhood plans? Thank you.
Excellent questions, Neha. Over to you.
Thank you very much for the questions, and I really welcome them every time. I think I've already reached out to you following the last meeting, and we're meeting very soon to talk about how we engage with yourself and other partnership boards really going forward, but especially yourselves as carers. So for the first question, so the governance process for the integrator is still being worked through. We're still at that early stage, but please be assured that we have already started discussions about how the voice of local people is strongly represented in the new model. It's really important to us as a partnership. The second question, use of the population health information will be key to the new working arrangements to ensure that the population of Ealing have improved responsiveness from local services. The £200,000 is only one-off monies that are currently being discussed in terms of how they can be applied to the benefit of the implementation planning, including amplifying that resident and citizen voice going forward, but also get better at our communications as a partnership. And the third question around carers and residents' voices being built in. So while West London NHS Trust is the nominated host integrator partnership, it is the responsibility of the collective partnership of the GPs, the community services, the mental health services, the acute provider, our voluntary sectors, and all of us working together to include those citizen voices in the development of any neighbourhoods. And as per the response to the question above, the partnership already looking at how we can have a better alignment with our community engagement model, which builds on the strength of the existing engagement frameworks, including the co-production boards that we have, but also ensure that there's a strong, the strength of voice at local communities. So if we're doing Ghibli Gardens, for example, how do we make sure that that local voice is heard from the wider community in that area?
Thanks very much, Neha. So I'll come to Lorraine next.
Thank you. Echoing what you've already said, I have a different question in relation to how you will communicate this change to people in digital poverty or where English isn't their first language. Thank you.
Thanks, Lorraine. Neha.
It's a really, really good question. And I think this is where we need some of that support from the co-production boards that currently exist. And we've been talking about how we strengthen our participation in those co-production boards. So we're getting that support to think through some of these things about how we best do that, especially with digital exclusion, but also, actively listening to the feedback and then coming back with the responses as well. But, we'd be looking for the co-production boards to help us think some of this through.
Thanks, Neha. So also pleased to be joined by Councillor Newstab, who, as I mentioned, is our cabinet member. Councillor Newstab, did you want to come in?
Yeah, hi, Chair. Hi, Councillor Weston. Hello, everyone. Sorry, I can't be there. Hot off the tails of a couple of days at NCASC conference. There's an awful lot of discussion around neighbourhood health and our collective role in that space. So less of a question and more of a sort of call to arms, really, is that I genuinely think we all have a collective responsibility to support the what we would traditionally think of the health systems, but to drive our support the drive to map our voluntary organisations, our existing local authority organisations, to really genuinely think about how we can meet those collective local needs and think more specifically about how we drive adult social care and children's obviously into that partnership, so that we can finally work harder on the prevention at a very localized level. So these are very live and hot topics, and I look forward very much to working with the NHS in partnership and to be doing that effectively. So it's very unsettling times, and thank you, Chair, for saying, as I try to in all of these meetings, is that we do understand and have great empathy with the sort of difficult change that's going on. But I do genuinely think we're at a point of cautiously optimistic change, where we can genuinely drive some of these things and think about the wider determinants in that conversation, to be really thinking about better outcomes for people that aren't just about fixing medical need, but really doing things further upstream, so that we can be far more effective together.
Lovely, thank you very much, Councillor Newstab. Any further indications from panel members? We're always delighted to be joined by colleagues from Ealing Save Our NHS. So if there are no further contributions from panel members, Martin, would you like to come up and ask your questions? There's a microphone just here for you.
Thanks. I'm sorry to say I'm not optimistic at all. One of the feelings I got when looking at this stuff was, and now I printed some of it out so I could read it properly, was that we've been there before. It all sounded very familiar, of trying to do more with less. And it didn't work last time, and I have a fear that it won't work this time, which is why I've posed some questions asking for commitments. And the experience I have is I've been involved in Ealing Save Our NHS for something like 14 years. God, yeah, really that long, almost since I retired. And when I was at work, not in the NHS, on the London Underground, for your information, we had very much the same thing, and it all fell apart. And they privatised us, but because we were the Underground, and London can't function without the Underground, they renationalised us again, although they kept it very quiet. So these are my concerns, based on my experience, both at work and in campaigning for the NHS, which I've been more or less continually doing since I retired, as Nihal knows. And this is not a criticism of anybody at all, because I think Dr. Taylor actually put his finger on it when he said there's a lot of uncertainty.
I'm going to have to push you for the questions.
Yes.
Martin, sorry, because we are running to time.
So the question is, for this panel, it's a three-part question, really. To what extent will services be privatised to deliver NHS productivity? We hear a lot about privatisation from West Streeting, so I think it's fair to ask for an assurance on this matter, because it is unclear. And I heard Nihal speak about PPP, which is, in my experience, has been disastrous in the past and has been extremely expensive. Secondly, please give practical examples. Can the ICB, Integrated Care Board, guarantee that there will be no cuts to services? Because this is where it really counts, services on the front line. And when will detailed financial planning be done? Because all of this is actually quite meaningless without the financial details, or at least some financial information. So that's my question. It's fairly brief.
Thank you you very much, Martin. Appreciate that. Neha, Dr. Taylor, I'll come to you.
Thank you. Very brief, but very big questions as well.
Yes.
In what you've asked. So what we're talking about here is when we're talking about the cuts, I just want to be really clear. It's the cuts to the ICB staffing budget. It's not any cuts to services that we're talking about in these restructures. So I just want to make that really clear. In terms of when will the financial planning be done, it's constantly being done. I haven't got it to hand to be able to answer some of those questions, and more information is being published at the moment on the new operating models for the future, and the financial allocations have only recently just come out, so I'm very sure our finance team are working through that. But the ICB board meetings would be a good place to hear about how that would translate into services. And in terms of privatisation, I haven't heard anything about privatising any other services. This public-private partnership is a way of funding. My understanding is, I really don't know the details, so I don't want to even pretend to know the details. It's about having some capital monies to be able to redevelop the Jubilee Gardens Centre to make it a neighbourhood hub for us in Ealing, and one of, I'm sure, that will be many.
Yeah, all I wanted to just add is just to reaffirm that these changes within the ICB structure has no bearing on frontline staff or frontline services. This is purely about how the strategic commissioner will be in the future in relation to delivering those strategic decisions. Their providers, the frontline services and the frontline staff will continue as they are now. So I want to just assure everyone regarding that. This is the cuts in relation to the ICB. This was a government directive that ICBs need to work within a financial framework of £19 per head of the population. So everything within the ICB, including all the offices and all the staff that work in the ICB, have to work within that financial envelope going forward from the April 2026.
Thanks very much for those answers, and thank you, Martin, for the questions as well. Appreciate it. Sure, thank you. So, colleagues, we've had a helpful update, I think, from Neha and Dr. Taylor, and a good opportunity to ask questions there. We will obviously continue throughout our scrutiny year to monitor key developments. I think particularly we'll look forward to updates on the leadership position in relation to the ICB and those kind of key financial questions that were asked, as well as some of the challenge I think that Lorraine brought in around communications and how we're really landing the message. So really grateful to Neha and Dr. Taylor for their time this evening. At that point, we will move on. Thank you again. So we're now moving to item 8, which is the Safeguarding Adults Partnership Board Annual Report and Assurance Statement for 2024-25. So Robert McCulloch-Graham is our independent chair of the Ealing Safeguarding Adults Board. Robert has attended several scrutiny conversations now, and we look forward to hearing from him about the annual report and the assurance statement. So I will pass over to you, Robert.
Thanks very much, Chair, and thank you, colleagues, for the invitation to come and present our annual report to you. I think, as in previous years, I just wanted to give a quick explanation as to the functions of the Safeguarding Adult Board before I go into talking about the actual report. And you've had copies of the report, so I won't go through in any particular detail, and perhaps we can get into a bit of a conversation and questions at the end. So firstly, the board itself is here to give are to seek its assurance that we have safeguarding systems in place across the whole of the partnership. And it's a wide partnership which includes our health colleagues, both the ICB, the commissioners, but also the trusts. It includes the Metropolitan Police and our Borough Command Unit, as well as the council and the council services, and in particular adult social care. It also takes in a number of voluntary agencies as well as representation within that, and we have the DWP have now joined our ranks and been represented on the board as well within that. So that's incredibly useful for us, and there's been some national work done with DWP around safeguarding. So to see it coming in locally for us is a real strength. So how do we seek that insurance? And so one of the fundamentals of the board is that we ensure that we carry a degree of independence. When each of those agencies join the board or are represented on the board, they have two roles. One is as a representative of the body that they come from with their own insights. The second role is to provide that degree of independence and challenge so that we can actually work collectively to ensure that we have continuous improvement and that we do actually safeguard adults across the borough within there. So the report itself this year has been improved from previous years. We've got more information and more data that we presented in there. And the report follows the 6 principles of safeguarding. So we seek to empower individuals so that they can look after themselves and reduce their own risk. And we do that through the agencies. The board doesn't do this directly, it actually does it through the services, and we assure ourselves as a partnership that that's actually taking place. We work with those services to ensure that we have a degree of prevention through all our services so that we're better equipped to actually reduce that degree of risk that's present in the communities. Proportionality, we ensure that our services are actually intervening in the right sense and not overtaking people's lives. And there is a degree of control, particularly when we come around to things like deprivation of liberty and dealing with individuals around their own determination and whether they have capacity to undertake that. So it's a very difficult area that a lot of our colleagues around this table do in, day out. We seek to protect our communities, and some of our communities have more characteristics that lend towards a higher degree of risk, and we have to be aware of that. And we take some of that data in the referrals that we have, ensuring that they're representative of the population across Ealing. Partnership is the strength that we provide. So as a collection, we actually provide more than the sum of the individuals that are there. And we have to ensure that we are accountable to each other. So the degree of independence is vitally important in everything that we do within there. And we have a number of subgroups which meet and support the board, and they've been reported within the report itself. And a few areas that have been developed over the last year. So the previous year we had a ministerial direction that all safeguarding adult boards should have an element and a priority that have a look at rough sleepers within the community, and we've done that, and we have representation in the partnership now, which is helping us with that particular piece of work. And that in particular from our health and our housing colleagues that have helped us with that particular area, and that features within our priorities, and it's going to feature within our strategy moving forward into next year. So the challenges that we've faced this year, I think some colleagues, particularly with our health colleagues, have expressed some of those issues that we've faced in the year that's just gone, but the antecedents of them were in the year that this report has actually been reporting on. We've seen an increase in the number of referrals coming into our services. We've seen an increase in the complexity of those referrals, and in particular around our health colleagues and their front doors, we've seen an increase in the level of acuity that's actually come in as well. So whilst we've seen pressure increase across all of the services, we've been able to respond in a way that's actually maintained our progress on that. So I'm pleased to say that within those referrals that are coming in. In the past, we've had some backlogs that we've had to deal with, particularly within adult social care, and we've seen them reduce dramatically and actually to be staying down as well. One of the fears that we had across the partnership that would just shift into other areas of the partnership, particularly within health colleagues, but the partnership has managed to maintain that, and we haven't seen that transference of pressures from one agency into the other, so it has actually been dealt with.
I think we may have lost you, Robert. Can you hear us? Is that... Councillor Newstub is still moving, so I think it's a Robert issue. Yeah, you're very much still moving, Councillor Newstub. I think what we will do is if we could try and get Robert to rejoin. If it's okay, Avatar, what I might do, rather than pausing here, is I might come to you for item 9, if that's okay, and then we'll... Oh, hang on. Robert, you're back.
Right. I think I realise what's happened. I'm not in my normal place. I'm in limbo, and I'm actually having to use a hotspot on my phone, so probably that's what the difficulty is. So hopefully it should be okay now. Shall I continue, Chair?
Yes, please do, Robert. That would be great.
Okay. I'm trying to look. Sorry, bear with me 1 second. Right, don't have too many cables. Right, okay, apologies for that. I'm not quite sure how far I got. I was talking about the previous year and the challenges, I think was the last bit I was talking to. So
That's right.
We've been a significant increase in the challenges come through to the partnership, but we've also seen an increase in activity, and we've managed to deal with that increase in numbers, but also increase in acuity and also increase in the complexity. And we've actually seen the completion of those referrals. So, and the report, the annual report, has explained how we've managed to reduce the level of risk, which is really pleasing to be able to report back to this group and to others. And it's a good thing that we've managed to put it within the report itself. The report goes on to explain the types of abuse that we're actually seeing in kneeling and where that abuse takes place. The majority of the places tends to be within the people's own home, but also within our care provisions, so within a residential home and also our nursing homes within there. That tends to be the major areas where they're coming from. The report has also detailed that where we have a significant incident, it is one of the duties, the 3 major duties that we have. One of the major duties is that we undertake a safeguarding adult review when we have a significant case where we believe there'll be some learning for us. The SAR subgroup has delegation to decide whether or not these cases meet the criteria for a full review. We've had 7 referrals in that time. 5 of them didn't meet the criteria for a full review. We felt there wasn't significant learning to be had. However, all of those cases were referred back to the referring agency and other agencies which were relevant to carry out a particular internal review rather than a full-blown SAR. We did, however, take 2 forward. And we've appointed reviewers for them, and work is continuing, and we expect those to report back probably by the end of spring next year. And the first case was a 35-year-old man who had specific health issues, and one of the concerns were around not taking up services, but also the housing conditions that he and his mother were living in. So we'll be looking at those services in detail through a panel, which is going to be a multidisciplinary panel and chaired by an independent reviewer. The second case was of a 77-year-old man with issues of self-neglect. He was engaging with services. There were a number of services engaging with them, but unfortunately, collectively, we weren't able to actually provide the services which were actually reducing the inevitable with his passing, which was mainly caused through self-neglect, but also significant use of alcohol at that time. we weren't able to change the behaviours. And so the review will be focusing on, even with that level of resource, how are we not able to get this individual to benefit from all of the services which were made available at that time. So those two reviews, we expect significant learning to be had for the local partnership, but we also suspect there will be some national learning to take out to the national panel and across London as well. The reports, I think for the first time, we've indicated the training programme that is put on across all of the partners. There's a very good question that's been put here. Hopefully get a chance to answer it at the end. At this stage, we've given a flavour as to what the quantity of that learning is and the types of training that's on. These are put on by individual agencies, and the direction of travel that we want to go in is to make sure that all of that training is actually open to everybody, so that we get the benefits across the whole of the partnership. So our health colleagues, police colleagues, adult social care colleagues and our voluntary sector all provide training programmes around safeguarding. The huge benefit that we want to gain is actually using that resource across the whole of the partnership. So that's the goal that we'll be moving to. But at this stage, in this report, is the first time that we reported the types of training that is going on currently. So we want to move on to that for the next one. There's an element of the budget within the report. And the final thing is that all of our partners have completed their own sections within this report as to what their actions have been over the year towards the objectives and the priorities that we identified within safeguarding in the partnership. So that's a bit of a run through. I'm sorry I've had a bit of a glitch with the IT, but I'll be open for questions now.
Thanks very much, Robert. That was a comprehensive summary. We're really grateful. I'm going to take questions. I'll start with Councillor Baines and then I'll go to Goulet afterwards, followed by Connor. So Councillor Baines, over to you.
Good evening. Thank you very much for that report, and thank you, officers, for your report. What would be our prevention plan for neglect, and how we track that in the to see whether the harm is reducing in the future? Thank you.
Robert.
Thank you, and thanks for the question. Neglect is our biggest area of concern. So out of all of the referrals that come through to us, neglect is by far the greatest, and that's not just locally. There's been 2 massive surveys of every safeguarding adult review that's been undertaken nationally. We have a national library now. And the biggest area that's reported is self-neglect, so it is a national problem. There is a board in the north of the country, in Cumbria, who's just undertaken a themed review across 6 cases. So rather than have 6 individual safeguarding adult reviews, they've themed them and brought them all together. Each of the cases, which has been reported the last couple of weeks, were all different, but the common theme was self-neglect. And what's interesting from that report is that the individuals were different, the environment was different, but the abuse was still self-neglect in that. So what we're learning is that there's lots of different drivers or antecedents for neglect, which lends us to say that there's probably a multitude of different reactions to it. So the biggest issue that we see is the non-engagement with services and the inability of us as professionals to actually ensure that engagement, to actually get people to take part in the provision, which is actually going to reduce that self-neglect. So there is no easy answer for it, and we haven't got one as yet, but the level of research and the level of knowledge that we have is increasing with it. Where we've had successes, so I've described where the failures have been and when we've done safeguarding adult reviews, but we have had significant successes. And in the main, those successes have come down to individuals, professionals from services, really being tenacious, very committed, and using a multitude of methodologies, tricks, approaches, whatever you want to call it, that are appropriate for that individual. So it's a case of actually directing a response to those individual needs with them. And that's some of the learning that we're actually seeing within that. Some of the cases have been particularly successful when we've had a multi-agency approach or an interdisciplinary approach, where people are pulling on multiple skills or multiple areas of resource to win over or to get into a relationship with an individual who has been quite difficult to engage with in the past. So we are seeing some improvement in this, although it still remains our highest area of concern.
Councillor Mains, is that okay for you? Excellent, thank you. Goulet, I'll bring you in next, and then I've got Connor and Alan after that.
Thank you very much for the report. My first question is, unpaid carers often describe reaching exhaustion, isolation. Oh, it's on. It's on.
I can hear it.
The line's just.
Yeah.
It's just on. The line's on the side,
It's-
but the line.
Okay, all right, sorry. So unpaid carers often describe reaching exhaustion, isolation, or burnout long before any service recognizes their situation as a safeguarding concern. What specific safeguarding measures are in place to protect unpaid carers like me from burnout, self-neglect, and mental health crisis, given that self-neglect is the highest recorded category of abuse in Ealing, including self-neglect caused by overcaring, and how will agencies intervene early rather than waiting until there is a breakdown in care or a safeguarding incident? Question 2, carers routinely act as the coordinator between several services, hospitals, social care, mental health teams, schools, housing, and benefit agencies. This system navigation is quite heavy and continuous and often unsafe. What is being done to reduce the responsibility placed on carers to manage complex multi-agency communication, and what safeguarding protections will be introduced to prevent this burden from becoming a risk in itself? And question 3, which I think you already touched on, is the section on the training provisions. The graph shows strong trust-wide training delivery, but without denominators for community and primary care. For each quarter, what are the total numbers of community and primary care delivery teams and staff requiring levels 1 to 4? How many completed it, and what is the team level coverage, so we can identify where the largest gaps are and the target the support there? And please clarify where the basic online safeguarding training, particularly on self-neglect and hoarding, can be extended to unpaid carers, including the eligibility, access, root cost, data capture, accessibility support, and time frame for measuring the impact. Thank you.
I'm not sure you took a breath there, Goulet. Those are the questions. Let's have some answers, Robert.
Okay, thanks very much, and thanks for the detail on the questions, actually. If I go backwards, if you don't mind, because there's parts of the question I can't answer, and I'm going to have to come back to you. But what I want to give you is some assurance, actually, particularly when you started to talk about the denominators for the training. I think that is a miss in our report. And that's something that we need to fix for next year's report, but that means we have to fix it now within our subgroups that's measuring the training going on. So we do have that information. We haven't reported on it in the report, so it is a miss. And that's something that we'll have to plug next year. So what we aim to do within this report is to give everybody a knowledge of what is out there currently, so that we can be reassured that we can move forward within that. What we haven't given you is the gaps. So that's what we'll have to do. But we do have our effectiveness subgroup, which monitors this, and it allows us to go back to individual services and to provide that degree of challenge to them to see, and also to give them help across the partnership, whether we can get solutions for that maybe there's some training elsewhere that they don't have to provide themselves. So that's the work of the forum, and that's taking place. But I think the assurance that it's missing in the report is exactly that. We should have those denominators, and we should be telling what the gaps are. I did try to explain that it's an area of future work for us, so it will be within our forthcoming strategy, and I'll touch on that later, actually. Right, on the issue of the carers, I'm still going backwards. So your second question was around the coordination that the unpaid carers carry out themselves. And that's a huge resource for services. And I can speak both as a person that's led services, so social services and health services in the past, there's a huge reliance on carers. I don't think that reliance will ever go, if I'm really honest. But it's the level of support that we can actually provide with them, which might make it a bit easier. The degree of coordination that carers carry is perhaps a bit of a warning for us. It's perhaps understandable because the care is at the heart of the individual that needs all those different services. So they are the one that's in constant contact, and they are the ones that are most aware of the needs of that. So I think that's always going to be there. But I think what we're seeing and how we're moving and helping carers, or what we need to do more of, is to ensure that each of the services, health, police, adult social care, and others, mental health, are aware of how much we rely on those carers and actually give a level of degree of support to help them with that task, because without them, we couldn't afford it at all, collectively across all of our services. So it is a case of actually providing as much support as we can, but also intervening in cases where we are close to burnout. And having a carer breakdown situation is the last thing we want to do when it happens, and it happens too often that it happens suddenly. And that breakdown means that other services have to come in a state of emergency, which is the last thing that we want to do. So being aware of the condition and carrying out more carers assessments so that we know what level of support needs to go in is vital within that. And I think we need to be doing more within the partnership as a whole around this. And what I expect us to do, we're moving towards redoing our strategy next year, and I think that's a particular area that we want to focus on to make sure that collectively we've got a response for that, because it just provides so much support that without that our services would not be able to function with them. So we know the primacy of that particular role. I think I probably covered the first question within that when it comes down to the exhaustion and the burnout. Actually, it's just a case that we need to be in there collectively as services, and also for carers to know where to go. Too often I find with carers that it ends up at the GP when we're very close to the breakdown, and it's the GP that triggers it, which brings it into acute. And then once we're in acute, we're probably too late for some of the interventions that we can actually do, staying too long in hospital. And if we got in there earlier, we could probably prevent that. So it's a case of actually getting that early support coming in. It's not as if people don't know this. I think everybody does know this, but I think we have to make a bit of a priority across the partnership to direct it in.
Thank you. So I'll bring Connor in now.
There we go. Hiya. So my first question was, while going through the report, I noticed there was essentially nothing there regarding people who are neurodivergent. I think it was touched on once or twice. Do you happen to have these statistics for safeguarding referrals to people who are neurodivergent? And also, what does Ealing do as a borough to help safeguard and protect people who are neurodivergent who may need extra support?
Thank you, Connor. Robert.
All right. We obviously don't do enough, otherwise it'd be in the report, if I'm really honest with you. My son is neurodivergent, so I'm very aware of the needs personally within that. And it is an area that I know cuts across a lot of our deprivation of liberties, our mental health issues, our learning disabilities, our self-neglect. It cuts right across all of it. So I think probably that is a miss for us actually within the partnership, and it's one that we are aware of, and it's one I think we'll put into our preparations for our strategy next year within there. I think it's come more to the fore actually within the last couple of years. I think probably post-pandemic that people are much more aware of it. It's always been there, but I think services are more aware, and the prevalence of it is more identifiable within there. I think it should be a focus for us moving forward. So I thank you for the question, and I think we will have a better response for you, hopefully, over the next year.
Thanks, Robert. Stuart in the room's going to come in on this one. So Stuart, over to you.
Thank you, Chair. Thank you for your question, Connor. Yeah, so absolutely recognise that we currently in the council don't record in that way to be able to report about people who may be neurodiverse and suffer safeguarding. Also referenced in the report is the transformation that we've been undertaking within the operational side of adult social care. And one of the key drivers for our long-term transformation is the creation of our working age part of our service, which will have a specific neurodiversity team within it. And what we are doing as part of that is challenging ourselves around how do we best meet the needs of our residents who are neurodiverse, which will include, of course, safeguarding responses as well. The timelines are for that we should be implementing that in March, April within the service. So that will really support next year's report when we'll have much better data. But it's a really good question and a bit we need to work on.
Thanks very much, Connor, and thanks for those responses. So I've got Alan, then I've got Councillor Dinsett, and then I've got Councillor Newsdub. And David, you will be our last contributor on this item. So Alan.
Yeah, a couple of questions. You actually show the location of recorded abuse. And what I'd like to see is some comparison figures from previous years also presented. With particular concern is the institutional numbers and what measures they have put in place to reduce any concerns. So that's one question. And the other question is a little bit nerdy. You talk about breakdown of ethnicity, and you've got 240 unknown, and also you've got 46 not stated. What is the difference between the two? Please.
We like nerdy questions, so Robert, over to you.
Right, I'm not so keen on them because I can't answer them.
Well, there's a man in the room that can, Stuart.
All right. Okay.
So on the second question, it is genuinely a recording issue. So the social, I mean, to be kind of get into the detail, because it has to be to answer a nerdy question, is that as the social worker or the practitioner is recording the initial concern, they're also picking ethnicity for the person. And in what it should mean is that not recorded is basically we didn't ask. And the second is the person didn't tell us. At the moment, we're not confident. This is the Ealing Council data. We're not confident that is accurate, and we are going through a process of data quality days actually across a variety of data sets within our council, within the recording system in adult social care, to correct those, so they should get more and more accurate. But that's the specific difference. I don't know, Robert might want to answer the first question.
And yeah, on the first question, Robert, about the comparable data.
Yeah, Stuart, thank you for the reply on the other one. So I take the point about the trend data, actually looking from year to year. I think that would be useful within it, but I tried to give you some reassurance because it's one of the areas that I sought assurance when I first joined Ealing, because it is an area where we get a lot of referrals coming in. And if you look at it, it's understandable why we do, because we have a lot of vulnerable people there, and we have a lot of professionals there, and we have lots of guidance, and we have lots of practice, and we have lots of legislation which forces that coverage and awareness there. So therefore, we're going to get more referrals coming in from those particular areas. So that's one thing. But that still means we've got issues happening there that we need to respond to. So it's not, you know, to cover that, but we do know it's an area of concern. And what the assurance I saw when I first came in, so this carries on. So I did this the previous report, maybe even the one before that. The local authority itself has a function, and Stuart, you might have to give me the name of the group, I've forgotten it, but it's a commissioning, a group of commissioners who undertake or keep eyes on the provision of residential care, domiciliary care, and nursing care as well. So we would get earlier concerns raised within that particular group, and we follow up with either a local inspection or people going around or some response to that level. And also within there, there's one factor which I thought was very helpful, is looking at organisations and their financial stability, because the last thing we want is for one of these organisations or facilities to fall over and suddenly we've got the care of a dozen individuals to intervene in. So having that foresight around there is vital. It's also vital because the regulator, CQC, are way behind in their inspections and registrations and deregistrations of this particular provision. And therefore, we need to make up for that locally, and our agencies do, by keeping their own tabs on how they're performing within there. So yes, we see lots of referrals coming from that area, but there is a high degree of risk. There are very vulnerable people in there, but there's also a big bunch of professionals who raise those concerns, and that's why they're recorded. But it is important that we do have lots of agencies keeping eyes on those institutions, and I'm pleased to report that that's what happens in Ealing, and it needs to be maintained.
Thank you, Robert. Stuart, everyone is waiting with bated breath for the name of this group, so please put us out of our misery.
Gladly, Chair. It's the Provider Concerns Board, and it's made up of provider concerns, contract monitoring teams, and colleagues from across the system.
Excellent. Thank you very much.
Stuart.
Alan, any follow-ups from yourself? Excellent. Councillor Dinser, over to you next.
Thank you very much, Chair. My questions are from the report itself. The report talks about communication challenges between professionals and organizations. So in that context, what are the biggest communication problems between agencies and how are you fixing them? And the second question is, the report also talks about difficulty in releasing staff from mandatory training. So how can staff get better training when they are so busy? And what help is there for their well-being? My third question is, and actually, I want to thank all the wonderful work you have done in terms of the people in the case study. And this leads me, there are a couple of individuals referred to in the report as AS and JS. There are a number of people in Southall who are undocumented rough sleepers. Is there any way they can be helped like these two individuals were? And again, just want to express my thanks for this wonderful work which has been done.
Thanks, Councillor Dinser. Robert.
Yeah, the work is incredible, actually, and it's the individual services and it's the individual professionals that work in those services that deserve the congratulation, actually, rather than the board or the. But it is a partnership of services at work. What's been reassuring for me since this has become a national priority, I think it's always been a priority for all of our services. People have been rough sleeping, but it's now a national priority for us all. And I think it's spurred on some greater appreciation of the ability of those people at work very close to this community of individuals there. It's a real skill to get alongside and to work with them. There are lots of challenges and there's loads of difficulties about actually doing it. We now have a board member who represents that particular group and leads those services. So we get direct input into our partnership. So it's really provided a better insight as to what the challenges are with those groups. They're very transient. So just when you think you've got your hands around the issue, they change. They've moved on somewhere else and you've got another group to deal with. So that's just one of the things that we have to do. Gaining trust is another. There's a lot of fear of officialdom. There's a lot of fear of professionals coming in. So having that ability to be a professional, but yet have the skill to be empathetic and work alongside them, and to have this understanding as to why have they made their home outside, or what is the rationale around this. And the worst thing I've ever heard from any professional, and this was a senior professional, not kneeling, I hasten to add, is saying that this is a life choice for individuals, and it really is not a life choice. People have ended up there for a multitude of different reasons, and the good staff, the ones that make a significant difference, understand that and actually can plan an individual route to support that individual going out from it. And there's lots of, they are individuals and there's loads of different reasons for it. So every case is different. And I think it's an ability to be tenacious and not let it go. And I think what's benefited us in the partnership is us having collectively and getting a bit of a collective response. But the big thing is going back to not just multidisciplinary working, it's, and I've used the phrase earlier on, it's interdisciplinary working. You've got professionals who might not be experts at all, but they are, you know, jack of all trades that can actually pull in some of those aspects, and they know the services, so they know where to go. And also quite often they know the individuals to phone and ring. And that's where you get a real power for it. So loads of challenges. I think we've made a significant start. There's no silver bullet. I think it's something that we've got to keep doing. And we've got to work out what those antecedents are and trying to do it. One of the worrying things that I've heard from that team is a number of hostels where the individuals, young adults, very young adults, are safe for however many weeks they're held in the hostel, but within 4 weeks of coming out, they become targets for gangs and for criminality and for drugs, and real soft targets. So it's trying to capture them before they're influenced elsewhere. So there is a wealth of information, it's a wealth of data that we've got now. And as I say, we're dealing with the transient group of people. So very, very difficult, but something we keep doing, and I think the people that are doing the work need to be applauded and continually within there and given all of our support to carry on.
Thanks very much, Robert. So our last speaker was going to be David. He's donated his question to Lorraine. So Lorraine, I'll bring you in.
Thank you, Chair. Thank you, David. It's really good to hear everything you've been saying in relation to the Safeguarding Adults Board and the work you're doing, the expanded lens by including other groups and membership. Are there any other plans to include the community and voluntary sector or faith groups to help support isolated, vulnerable adults? Because there are good relationships with these people, and you've talked about them being afraid of, you know, professionals. We have those relationships, and we can help the board to either deliver culturally appropriate training or as membership to support, to identify and support these individuals. And I think relating to that is the feedback loop. So safeguarding by nature is a reactive event. And what I'd like to see more of is the learning that happens from those safeguarding events that lead into the provision of services. So what does that tell us about gaps in our services, and what do we need to do to support those people?
Robert.
Right. There's a lot in what you've just said, actually. I'll do it backwards again, if you don't mind. So the learning from the SARS, it's always an issue to make sure that you embed the learning. So we've come up with, you know, some huge reviews, very, very detailed reviews that have involved hundreds of individuals within the research and have gone back many, many years to understand why an individual's ended up where they've ended up. And that's always culminated in recommendations, quite often too many recommendations. But our job really is useless, or those reports are useless unless we've actually taken the learning from it and embedded it in practice. And we have action plans at the end of every report, and they have to be signed off by the board. And we have updates that are brought to the SAR subgroup, and any issues are escalated to the board as a whole. And we would intervene with any particular agency that wasn't following through in any of those recommendations with it. That all tends to take place within the first 6 months, 9 months. What we need to move on to is going back 12 months, 15 months, 2 years later, and checking those actions that you did then. are they still there? Because staff move on, so we need to make sure it's there. So one thing, make sure it's done in the first place, but then go back and revisit. And we haven't been good at doing that, and that's something we need to pick up on. Let's go back after a period of time and bring the reviewer back and say, right, okay, you gave us this, you come back in and check us again. Is it still there? Is it still working? And let's have another report to the board. And I am pleased to say with the board, it's there's a really good culture now in the partnership of appreciative inquiry about actually challenging each other and a real desire to learn. And people aren't, what's the word? They're not defensive, and they really want to learn. So that's a real strength, and it's a real encouragement to me that it's become a learning partnership, which is great. Right, and your first question, right, okay, was about using the communities much more. And I think there's a wealth within the voluntary sector in particular, and the religious and faith groups too, that we don't have that contact and expertise to hand. But our services are made up of this community. So we've got ready access to them, but we don't use it enough, really. So I think there's more that we can be doing with it. I can give you some specific examples where we've discovered some particular issues which relate to a particular culture or a particular faith group or a particular community, and we are now going out to try and actually see if we can get some individuals to actually help us get access where it might be difficult for us to do so in the past. I think all of our services have got that level of experience, either here in Ealing or they've got it from elsewhere. So it's not as if it's a new thing, but it is something you have to nurture, because it depends very much on relationships, because sometimes this is quite a difficult or fraught area, or it can be, and it's an area that quite often we see agencies or individuals avoid going into because of an anxiety, and we need to go over that. And we've seen some national reports that just come out from the National Panel for Children's around that, and how there is a need for more courageous conversations. But I think your suggestion and your direction is the right way. That's what we ought to be doing. We are doing it on a couple of the SARs that we're doing and the reviews, because it's a particular area of the community, and we're going to seek some help specifically around them, but those are individual cases. We need to be doing it on a wider case as well, and what that nature is. And I think particularly around, I think, some of our faith groups that we've got, there's a bit of a gap for us, I think, within the partnership, something we could pick up on. So I think it's the right area to look.
Thank you, Robert. Thank you, everyone, for your contributions as well. I think the point that you were making there, particularly around kind of building that culture of curiosity early doors, is really critical, because actually we don't want things getting to the position of safeguarding adults reviews, do we? We want to catch those issues early on, and that requires everybody involved in the partnership to really sort of embed that culture of curiosity. So I think the panel this evening.
Chair, go on. Sorry, can I just I'm sorry. You perhaps can't see, but I can see Councillor Newsom. It's been waiting to get in for a wee while. I don't know. You might not be able to see it in stream, but I can hear. I don't know. Sorry.
I checked with Councillor Newsom.
Are
you okay?
He's checked in with me and I'm fine. So the moment passed on what I wanted to comment on, but
apologies.
Listening avidly.
Excellent. So thanks again, Robert. I think just in terms of kind of next steps from a health scrutiny perspective, we would just ask that you kind of reflect on the conversation around some of the gaps that we've identified. I think there was a really good challenge that came from Connor, particularly in terms of the neurodiversity point, and Alan also talked about that kind of year-on-year comparison too, which would be really beneficial. Now, Councillor Newsted, do you want to come in?
Yeah, I do, because I've just had an idea. So Robert's work is always so fantastic and thorough, and obviously dealing, as you've just alluded to, that the sort of the end when something goes wrong. So, and the work that, and I've been working with Robert over the last couple of years and been enormously impressed with the with that cross-partnership working and the relationships that he's built with us, it might be helpful, and this is obviously at your discretion, Chair, to understand the impact that he's had from the perspective of someone in that partnership, to sort of see the other side of the impact of good safeguarding work. I'm not suggesting we get everyone to talk about everything that they do, but the specifics of how that safeguarding work has impacted across Ealing and in the partnership, which I know has seen significant improvement, just might be an idea for bringing some of the work that Robert's done to life. Just a thought.
I am seeing some nods in the room. I think that's a great suggestion. So we'll factor that into the work programme. And thanks very much for the idea. Great. So we now move on slightly behind schedule. Apology, colleagues, to the Better Lives, Better Days project update. And I'm going to pass straight over to Avatar Man, who's no stranger to the panel, and will provide us with an update on the progress made against the ambitions set out in the Better Lives, Better Days programme.
Thank you, Chair, and mindful of the time, I'll be brief so we can have more time for questions. So you may recall back in March earlier this year, we introduced the Better Lives, Better Days project, which is a bold, exciting project, completely reimagining how we provide day opportunities across the borough, particularly for residents with learning disabilities, autism, older adults, and older adults living with dementia. Our ambition is to move away from traditional models of care and create a service that really delivers real outcomes, more choice, more independence, and what we're really keen on in social care is to kind of deliver meaningful activities for the people that we serve across the borough. We'd like to keep the excellent practice that we've got within our day opportunity services and our two main sites that we deliver, but our ambition is to scale it up across the borough, scale it up in terms of the outcomes that we deliver. And what we'd like to do and what our ambition is for the next phase of this project is to deliver a new operating model, which is focused on community-based activities that are co-designed with our customers, both from a collective point of view and at an individual point of view. So this is really, really key that we deliver the outcomes in a person-centered approach. Our vision is also to increase choice and control. So one size fits all is not what we want to deliver. Increased use of direct payments and a mixed offer, an offer which the local authority can provide, an offer which our voluntary sector, our community groups, our providers can provide as well. Our vision also incorporates a person-centered planning approach. So with strength-based conversations, really listening to the outcomes and the aspirations of our service users. And of course, key to this is to deliver services closer to home. So we're moving away from a 2-site model to a 4-site model, reducing travel time and increasing accessibility across the borough as well. So that's the vision, and that's what we introduced in March. All of this, may I remind you, has been concluded and was grounded in extensive engagement with our customers, with our carers, our families, our stakeholders, to understand what matters most, what outcomes they are, how can we deliver services safely in the new locations, how can we shape our building-based services, whether it's provided by the local authority or a voluntary sector, but how can we design services beyond buildings, so really connected to the communities at a neighbourhood level as well. So what's happened since March? And the PowerPoint that we provided gives an update in terms of some of our activities. In short, we've been very busy. We've turned our plans and our ideas into action. We've reinstated carers meetings, both at Michael Flanders and Cowgate. We've also hosted online engagement sessions with our families and our carers. We've launched monthly newsletters to keep all our stakeholders updated with regards to the project as well. We've done quite a lot of work in terms of developing the new sites, the planning of the new sites. So we've invited our carers, our service users, our colleagues working at Cowgate and Michael Flanders, but also our wider colleagues across social care and health, reviewed the sites and delivered feedback. We've carried out surveys And I'm pleased to report the surveys have been pretty fantastic. 100% response rate from Michael Flanders and 83% for Cowgate. So that's really, really high numbers as well. And because of that, we've acted upon quick wins. We're not waiting to move to a new location. Where we can, we are delivering change now, and keeping that momentum. So we've got new timetables already in terms of activities for development. The carers drop-in sessions have been strongly welcomed, really key to designing our next phase, but really key to planning how we can safely move some of our most vulnerable residents in the borough to new locations. We've got an OT clinic at Michael Flanders, and that makes wider service availability way more accessible, and that's what our families want. We've got a new workforce development strategy and plan. This follows an extensive skills audit in terms of what our workforce is like, the key skills, the key interests, and how we can incorporate that into delivering more creative day activities, more meaningful interaction. We have done significant training in terms of person-centered planning with our social workers and with our colleagues at Michael Flanders and Cowgate. We've also committed to seeking accreditation for our day centres and our day opportunity services. That's accreditation for dementia, and that's accreditation for learning disabilities and autism, to make sure we provide services that are as good as we possibly can, and in terms of the best standard, sharing best practice as well. And we are building ongoing feedback mechanisms with our families as well. So families have said to us, they're really, really keen to know what their loved ones do during the day. And sometimes that can't be communicated. You know, our service users get tired or they've got dementia. So we're building a log in terms of a passport in terms of what they've been doing, what's been good, and key messages. And that's before we move. We're also looking at some service enhancements. So through the surveys and through our engagement, we know that some of our families would like an extended offer. So we are working through the process where Cowgate will extend its offer from 9 a.m. till 4 p.m. But Michael Flanders will retain its opening hours 8:30 till 4, and that's from the feedback we've had from our service users and families. But we are also exploring evening and weekend options. Feedback suggests the occasional need, so a monthly weekend, a Saturday, maybe one Saturday every month or 2 evenings. We're working with our families around that and planning what the outcomes, what the activities are going to be as well. But we're also listening closely to what matters. So some of the surveys talks to us about what families want and what our service users want. For Cowgate, for our learning disabilities and autism cohorts, it's around increased fitness and exercise, more outdoor activities and life skills, cooking, dressing appropriately, for example, but also in terms of having the confidence around travel training. So that's going to be built into our new timetable of activity. Michael Flanders, there's the occasional day trip, safe outdoor walks as well, but bringing in the essential services like podiatry, speech therapy and hairdressing, plus creative activities like pottery and music. The impact so far to date has been really, really positive. Our customers, our families and our carers feel very empowered. They can see the direct impact in terms of the influence that they have and the change that the local authority is making. This is the change, not just with the services that we directly provide. We are sharing this with our provider market, with our voluntary sector, and we're hoping to the next couple of phases in terms of this project is to deliver a collective way in terms of how we can deliver meaningful engagement. Thank you, Chair.
Thanks very much, Avatar. I am welcoming questions from the floor, so I'll go David, Connor, Gulo, all in a row.
Thank you for the report, Avatar. I know you mentioned with moving from 2 to 4 sites, we are closing down on transport time. And in the past, we've heard stories where people have been on transport for a very long time to get to a centre. Do we have projections to what we think the time would be cut down to from travelling from different areas of the borough?
So I'll try to answer that. So We know from our previous reports and the research we've done, the average time can be between 1.5 to 2 hours a day. That is not a good use of time. You know, there's so much more we can deliver with that. The research that we've done to date, we have identified the closest location where people live, and there will be a reduction in the travel time. I can't tell you what it is, and that's primarily because the feedback we've had from families now is this is closer. Actually, we want to walk our family member to the service centre, or we want travel training so we can be more independent in terms of how we do it. This all comes down to the delivery and the implementation, and it will be person-centred. In the main, there will be a reduction, just can't quantify that until we start the move.
Doctor Connor.
So in the report, it states people with autism and learning disabilities. And I was thinking autism is not the only condition that would make you neurodivergent. There's ADHD, OCD, dyslexia, dyspraxia, and many others. Is there any room to try and open this up to people who could have any type of neurodivergent conditions, or is it just autism? And second of all, in the section that says for the spaces, it says autism and sensory friendly spaces. Can you just give a bit of a definition as to what that space could be, please?
After.
If I start with the second one, if that's okay. So in terms of the spaces and sensory services, that's co-designed with our service users. We know that there's a want for that, there's a need for that as well. That's the only one of the ways that we can provide a safe service. Particularly when, like you suggested, Connor, we expand the criteria to include other groups within neurodiversity and neurodivergency, and with LDs. What we currently provide is services for high need, high complex, and because of that, it's about the safe planning and the impact. So yes to commitment, yes to expand safely. But the way it's going to be done and the use of the space will be co-designed with our service users.
Stuart, you wanted to add?
Yeah, thanks for the question. Just to add, so just to build on Avtar's point about the fact that these services for those with the most complex needs, they're people who will need support all the time, someone with them all the time, and diagnosis would not be a barrier. So I think that's a good point, well made. But what I would also add is that, you know, for many of our population who draw on care and support, we would be looking for other things in terms of daytime activities. So learning, work, socialising with friends, etc. So this building-based day service, particularly for working age adults, will be targeted at those with the most high needs. And we're working with our social work teams to look at better community activities for other people who might benefit from those.
Thanks very much. Gule.
Thank you, Aftar, for the report. My first question is, the project aims to improve access by expanding to 4 sites closer to home. As an unpaid carer supporting someone with complex needs, transport remains one of the biggest barriers to consistent attendance. What concrete plans and timelines exist to ensure safe, reliable, and affordable transport for service users so that carers are not left filling the gap when public or assisted transport is unavailable and when they cannot do escort duties as they cannot get respite, as have to do the drop and pick themselves, leaving them with very little time for respite? Question 2, the vision emphasizes respite and supporting families, yet unpaid carers often still struggle to secure predictable high-quality breaks. How will the new flexible timetables, including evenings and weekends, translate into guaranteed regular respite for carers of people with high and complex needs? And how will the council measure whether carers are genuinely experiencing increased relief? Question 3, given the profound impact of staff expertise on both user well-being and carer confidence, how will the council ensure that the workforce development ensures consistent specialist skills across all 4 sites, particularly for those with dementia, autism, complex needs, epilepsy, communication difficulties, or mobility challenges? What safeguards are in place to prevent staffing gaps or inconsistent skill levels during the transition period? Thank you.
After.
Thank you. So with regards to the first question around concrete plans and timelines to ensure safe, reliable transport, Community transport will continue to be available at the new sites. It is part of our ongoing engagement. And as I've said before, some families have already expressed a desire for alternatives, such as walking or travel training for independent travel as well. The reduction in the travel times is one of the key drivers to why we are moving to a 4-site model to have accessibility across the borough as opposed to just 2 sites. Closer sites and the opportunities available will reduce travel times, but we will be managing that process through the transition as that takes place. The second question regarding respite and supporting families and flexible timetables. We've had a series of regular meetings with families and carers, and this has been raised and it's been fed back to us in terms of respite, and that would be built into a care plan as well. Our intention is to have a person-centred plan for each individual, for each customer. Respite will be part of that. Carers assessments will be part of that as well. So we will signpost to the services where appropriate as well. Travel options will be discussed. It's around the person-centred approach as well. But what I would like to do is, in terms of the demand for flexibility and evenings and weekends, the survey that I spoke about earlier, 55% of our service users and families at Cowgate said they don't want evening or weekend activities. 33% said yes, maybe 1 or 2 sessions a month. The remaining was unsure. For Michael Flanders, 92% said no to evenings or weekends. But I recognise that is the current number of service users. As we build our model, as we have a new target operating model, it will change and we will respond accordingly as needs change. Your final question regarding flexibility and staff strengths as well. There's a lot of staff expertise that we've got and we want to build on that. We don't want to lose that. We want to build on that and scale it up as well. There's been a lot of training that we've done, skills audit that's been carried out as well. And that training plan is being actioned as we speak now. So we've got a new timetable working through, we've got refresher training as well. And all of this is going to be reflected in the adult social care kind of workforce development plan as well. We have commissioned NDTI, which is the National Development Team for Inclusion, who have also led into this work, brought in best practice from other areas as well. And it's going to be an ongoing part of our work and our commitment to the accreditation that we need.
Excellent. So turning to our Vice Chair, Councillor Steed.
Hi, thanks for the additional information provided on top of the report. Can you just clarify the exact situation concerning the Michael Flanders Centre? Short, medium and long term?
So I understand in 2019 there was a cabinet report which talked about the development of the Michael Flanders Centre. In response to that, we are moving to 2 sites. We are relocating the services across the borough, and that's going to be in the medium to long term.
You can.
So with respect, when you talked about services moving from 2 to 4 centres, is that actually the case? With flag not going to be used?
So the services that we provide at Michael Flanders will be delivered in 2 separate sites.
Right, so there's not going to be 4 centres then?
Then we have Cowgate, sorry. So to answer the question before, sorry. So Michael Flanders are a day opportunity service for older adults, and older adults with dementia will be moving to 2 sites. So we've got a geographical spread across the borough. Cowgate, we will also be doing the same. So we've identified in the first instance 3 PFI buildings that we've got with purpose-built day centre facilities. One in Southall, one in Acton. Where's the third one? Remind me. Not too far off, but Councillor Newstart may remember. But we are going to have that spread. So we are moving to a 4-site model, yes.
That's fine. Stuart, did you want to add to that? No. Oh, fine. What we'll do is we'll make sure that we get that clarity for you, Councillor Steed.
Sorry, Stuart, can I just to be really clear? It is 2 sites to 4 sites. There's 2 services moving to 4 sites,
Okay.
but in terms of the detail, we'll provide that as we go.
Let's if we can take this one offline. I'm just mindful that we are massively behind time now. Lorraine.
Thank you, Chair, and thank you, Avatar. How are we supporting non-English speakers or people in digital poverty to understand how they can access these services? And secondly, how are we measuring outcomes to demonstrate the value that these services bring to those people?
Avatar.
Thank you. So in terms of non-speaking English, the workforce reflects the population. And that's the workforce in terms of those that provide the service at our current centres, but also our social care workforce. It's all around person-centred planning in terms of what the outcomes are, what the aspirations are, and developing an agreed plan about how we can meet those aspirations and those outcomes. In terms of measuring the outcomes, it's subject to regular review, subject to regular changes as well, and feedback. Families have expressed to us already they'd like to know more around the activity. We're not going to stand still. When we develop a target operating model, it will be constantly reviewed, constantly changed in terms of what we know works, but also what we know in terms of what the outcomes of our service users are, both at an individual level, but also at a collective level.
Thank you very much. So I'm not seeing any further indications from panel members, but we do have a question from John Moffat from the Ealing Reclaim Social Care Action Group. So John, if you want to ask your question, that would be great.
Yes, thanks for that. Roy Willis is sorry he can't be here to ask the question, so I'm doing it instead. The report mentions the co-location of dementia services to Sycamore Lodge. What will this mean in practice? Is there a danger of the facilities at Sycamore Lodge being overloaded? Will any established carer groups and will any established carer groups of voluntary organisation projects have to move out of Sycamore Lodge or rearrange their projects as a consequence? There's also another transport issue. How will transport and escort arrangements be managed as people with people with learning disabilities start to move to Martin House? Will both Cowgate and Martin House have vehicles and staff to enable severely disabled to attend day opportunities?
Thanks very much, John. Avatar.
Thank you, John, for those questions. So this is a significant partnership at work is what we've done. We've been working with the carer service, we've been working with some of the voluntary groups and the NHS that are currently operating out of these buildings. And what we are moving towards is a consensus in terms of how we will ensure a safe service for all the partnerships concerned. So that's our health colleagues and our voluntary sector as well. We are stepping through that as we speak. We're taking our time on this project for that reason alone. What we don't want to do is make an overnight change. So it's trial and error and method where we're going to test what works. In terms of the transport, your question regarding the transport and the needs and the complexity of our service users, carers and families have strongly fed back. Please, whatever you do not flick the switch overnight. Do not close Cowgate tomorrow or relocate to another service and that's it. Do it slowly. Start with 1 day a week or half a session at a time. Do it slowly until our service users who are used to having services delivered in one building get used to another one. And that includes the transport options, which we currently provide, as well as the move to the new locations. Everything will be done at the right pace for the individual.
Thank you very much, Avatar. That was great, and thanks, John, for the questions there. Can I just say, I think in terms of the what was really pleasing about the report was that focus on person-centred care. I think that's a really important thing that's often kind of overlooked in terms of business need, but actually ensuring that people are at the heart of what we do is critical to effective service delivery. So thank you for that report. And we now move on to the final substantive item on the agenda, which is technology-enabled lives, supporting through tech. Stuart, I'll hand over to you. I would just ask if we can keep the intro remarks short, and pithy questions and short responses will make good progress through this item. Thanks.
I'll do my best. So, building on the person-centred part, Chair, I wanted to start off by just highlighting the case study at the end of the report of Freddie. Freddie is a young woman with a learning disability and with other physical needs, and she wanted to learn skills. She wanted to organise her day. She wanted to be able to attend her horse riding centre without the need of reliance on her family or on her paid carers. And Freddie was provided, not in Ealing, in a different council, with an Alexa show and also with a brain and hand app. And by using both of those, she was able to organise her day, have prompts to get herself ready. Her family were able to go to work, and she was able to attend her horse riding session, which was important to her. If Freddie turned up to Ealing today, we wouldn't provide that. So in the summer, we partnered with Hampshire County Council and PA Consulting, who are leads in the technology-enabled living area, and we carried out an analysis of the current service in Ealing to develop a business case. I won't go through all of the detail, but it highlighted a number of strengths and limitations, and in particular our limitations currently is that we have quite a traditional offer of technology. It's very much aimed at older adults. There was then delays in terms of provision of care, although I'm happy to report, Chair, that those delays are no longer with our transition to Mediquip. And we had good feedback from practitioners to saying they really value tech but didn't have the confidence or the awareness, and residents said some of the things we've heard today was they want personalised assessments and better information when thinking about technology in their lives. So we've set our vision in terms of how we want to be as a council. We want to be curious and creative. We want to be collaborative, and we want to be leaders in terms of how we use technology to support people to live their lives in Ealing, and particularly those people who draw on care and support and their carers. So what will change? We've got a 5-year plan of things to change. So we want to move from this focus on just older adults to all ages. We want to move away from being prescriptive about equipment to focus on outcomes and then work out later on what, if any, technology can help, which will allow us to harness the technology in our pockets and on our wrists every day. We really like that cultural change within our staff team to really think about technology whenever they're thinking about how best to meet someone's social care needs. We want to use the data that comes out of that to be proactive, to work out how we can intervene before or as risks are emerging. But we need to do this within a robust governance framework. So that's not just about information governance, of course, but it's also about effective, high quality technology, making sure that we build on our partnership with Harrow Council in terms of the offer that we have there, which is excellent in terms of the response. And we also have a physical response in Ealing, which is something not all councils have. And it's a really, really, really good strength of ours. So we've done that piece of work. I'm here to report where we've got to, and we have our business case, and we are now starting to embark on that 12-month pathfinder with our current partners to kind of test, learn, and refine that model for what it would look like for the residents of Ealing, at the same time as starting to harness some of these new technologies that are coming through. And when I say new technologies, they're new to us in social care, because Alexa is not new, of course, to harness those, particularly for our working age population. Our working age population who draw on social care support are the people who use our support more than any other group in Ealing. We spend more money on those people, and actually at the moment I don't think we're giving them the best outcomes, and this is just one part of our approach to support that section of our population better. So happy to take questions.
That is excellent. Thank you, Stuart. And can I just say, I think this is a really impressive piece of work, the study. And I remember having conversations whilst over at Harrow with Avatar, and it's really good to see this work coming to fruition. I think it also builds on some of the work that we've been doing with AI, particularly in terms of social care notes and those sorts of things, which really provides Ealing with the opportunity to be at the cutting edge of some of this stuff. So Gule, I'll come to you and then I'll take any other questions.
Thank you very much. This is a very interesting topic. My first question is, how will you embed genuine patient care voice at every stage, assessment, selection, training, review, capture and measure this, reflecting Scandinavian practice, the Denmark, Norway and Sweden, which has positive success rate that keeps the patient at the center and asks what matters to you when tailoring tech to individual needs? Second question, how will tech augment, not replace human contact? What protocols will trigger in-person visits or social support referrals, e.g. isolations identified during installation, etc., ensuring the human dimension of care is preserved? Question 3, how will unpaid carer well-being be measured and supported? Routine stress, strain scales, respite triggers when alert burden and their input rises with tech, and what actions are required? For example, offer carer training, provide 24/7 helpline details, flag high alert frequency to care coordinators and providers. And lastly, I'd just like to add, for the second time in the last 8 months, I had a telephone set delivered for my 87-year-old father from Deaf Plus. First one was taken away by NRS, and then they went into administration, so it disappeared. Second one, they came, they installed it, and the technician said, yes, that's working, and it's not working. So I contacted the person who arranged the delivery, and what she told me, what I wasn't at home, she told my 87-year-old father, go and knock next door or call a friend in to help you install. So how can we stop this building up into your future plans? Thank you.
Thanks. Over to you, Stuart.
Thank you, Chair. Thank you, Gule, for your questions. In terms of your first question about patient care voice, you'll notice in the report that we had 3 sessions with residents, and that was at the business case stage. So hopefully you can see our commitment to co-design through that, and we will continue on that vein as we move along. Once we start to get to individual support plans which include technology, they'll all be built on the outcomes that the individual wants, and by that way, we not only are we doing the designing with residents, but actually what really matters is what happens in that person's home at that point. In terms of your second question, absolutely, we are clear as a council that technology is about enhancing community connection, not replacing it. And I think one of the case studies in the report shows quite clearly there was someone who was with epilepsy who was afraid to go out, and actually with this kind of reassurance of some of the technology was able to go out. And I see this as a way of connecting people to their communities and not reducing contact. And also, not in the report, but there are many stories where people are able to stay in their own home through the use of technology. And if you are removed from your home to residential care, you might have social contact here, but your communities may well have gone and left behind. On your final question, around carer well-being, and the training and all those sorts of things, and also that experience you've had, and I'm sorry you've had that experience. We need to build all of that in, and there's different models of how you install technology and how the aftercare and the training. But one thing I would say about the training, it's so important. There's so much technology sitting in people's homes, whether it's prescribed by the local authority or the NHS, or indeed we just bought it, which is not being used. So that robust kind of follow-up, is this being used? What support is needed? Who needs to be trained? Particularly like things like brain in hand, which are quite unique to the person. That training has to come as part of the offer, and that's exactly what we'll be looking to do in terms of our new model.
Thank you very much, Stuart. So Councillor Dinsett, and then I've got Lorraine after that.
I might be showing my ignorance here. You talk about the case study. In which way did the sensors help Bishal stay safe at night without the extra care visits? So just trying to understand, how does the sensors help you stay safe without actually the visits?
Thanks, Stuart.
Thanks, Councillor, for your question. Yes, in that scenario, and in many scenarios, the sensors and the ability to remote monitor, whatever that might look like, often that's families or others being able to do it, provides the reassurance for the family and professionals that actually, and in Bishal's case, it was noted that he was only leaving the property for a very short amount of time and then was coming back in again, and therefore was not felt that was particularly a risk. But what the sensors can do is, if Bishal hadn't come back in after, let's say, an hour or two, that would then send an alert, an automated alert to the contact centre, who could then arrange whatever the emergency response could be. And that's either a family member or it's our own physical response. So that reassurance can be really powerful to, one, reassure actually this is okay. Yeah, people will do things that we might think are a bit risky, but actually it's okay. But also that extra added layer of protection of, well, if this is abnormal for that person, then we need to raise the alert. So that's how it works in that case study.
No worries. Lorraine, I will bring you in.
Thank you, Chair. I think tech-enabled services are a great way of being able to integrate into people's lives without interfering and really allowing them to live the best and fullest life that they can. To Goulet's point, and I've lost my question. Are there any plans to fund the voluntary sector to support community-based digital champions or to support with training? To Goulet's point around, how we support people to take on this technology.
Stuart.
Yeah, thank you for the question. So as we move through the kind of implementation and design phase, we need to think about, particularly about digital exclusion, and particularly about how do we teach people to use the technology. And there's different models for that. And I think the voluntary sector have a part to offer in that. And I think particularly there's kind of, when we look at our technology, there's kind of non-standard and standard technology. And I think there's something about how do we upskill the community and our partners to be able to support with some of that more standard technology. Some of the specialists is very specialist. And I think more broader than that is how do we start to have the conversation about actually using what you've already got? Because it's not always something that needs to be prescribed. An iPhone is massively powerful to be able to give you prompts, reassurance, etc., smartwatches, etc. So there's also something, the education piece for our communities, through our partners, through the voluntary sector, etc., to kind of up the awareness of how we can use these things we've already got to manage risk, to support people to be independent, to maintain contact, etc., etc.
Thank you very much. So, Councillor Steed.
Thank you. I noticed the report says there's no financial implications. Can you just expand a little bit on that one?
Yeah. So at this point in the business case stage, which we're reporting on today, there's no financial implications that we're describing today. Of course, as we move into implementation, designing the model, there will be financial implications. But in terms of the long-term or the medium-term financial strategy, technology-enabled using the technology-enabled living or technology-enabled care, as it was identified in the MTFS, it should reduce overall expenditure on social care. So there will be, in time, further reports around the business case and the financial business case in particular. But today it's a report around the business case and then the next steps.
Just timeline on that?
Yeah, so we're looking to start the 12-month finder in the first quarter of next year. So that's when we're going to start doing more detailed work and more detailed planning.
Any other questions from panel members? I think then, John, I'll bring you in from an ERSCAC perspective, if that's okay.
Thanks again, Chair. Yeah, you've probably answered some of the questions with this particular one. The study's welcome, and it illustrates many benefits of technology and social care in the future. It is worth pointing out, however, that many social care users depend on their family carers and paid workers to assist them to use of technology. Has the training and updating needs of this group been taken into account? And if so, how? Detail would be helpful.
Stuart, thank you.
Yeah, so as per the previous question, as we go into implementation, we'll have to get more and more specific about this. But if I just give you one example from a local authority that we've worked with, one of the things that we put in place was nighttime kind of bogus call sensors and other sensors that help people to stay on their own at night. And as part of that, we worked with the support provider who did the on-call, but also did the daytime care, and did specific training for the care staff so that they understood the technology, understood how to use it, gave a handbook, and in fact that support provider also kind of helped co-design that training. So there is training like that exists, but it will be very much context specific in terms of who the provider is, who the people they're supporting is, and I should say, and what the technology is. So yes, there are examples of doing that, and it's absolutely part of the implementation, the way that we will roll this out.
Thank you very much, Stuart. So I will come to Councillor Newstead for a final word.
Thank you, Chair. I just want to say how incredibly exciting this whole project is. It's really, and we're very lucky to have Stuart, who has worked in this area elsewhere and is bringing all of that experience and cohort of people that he's worked with. There are so many fundamental shifts in the opportunities that technology presents in this space, and it's really encouraging to hear everyone's very positive response to it, because I think sometimes it can feel scary, right? But I think the way to start, for me, the way to start thinking about this is just the opportunities that we all have, and to use technology and all the things and the ways in which it's improved our lives to a wider cohort of people. And it's really interesting, to Stuart's point, like some of it's very, very specialist and has been designed in a very unique way to meet a particular challenge, and others are just like, how do we use this technology that we're surrounded by all the time to improve people's lives? And there's something really, really interesting as well, is that inevitably, within adult social care, we focus on those of our residents who are Care Act eligible, the people that we work with most specifically. But actually, if we can become this leader on this for wider numbers of people within Ealing, I think it's a really, really good sort of white mark of quality or recommendation or advice to other residents who aren't Care Act eligible, that they can be reassured that these are some of the things that we've worked on that we can recommend to a broader audience, which I think will be a really good position for us to be in.
Thanks very much, Councillor Newstead. So that brings us to the end of the item. Thank you, Stuart, for the presentation and the report as well. We look forward to hearing about developments as the project progresses. Certainly some exciting opportunities there. In terms of the next item, it's just to confirm that the next panel meeting is on the 29th of January. Thank you, members, for your participation tonight, and to all of our presenters as well. And of course, thank you to our questions from the Ealing Save Our NHS and ERSCAG. We really appreciate your time. I'm not going to wish everyone a happy Christmas just yet. I think it's slightly too early. But I
go for it, Chair.
I do hope you have a nice evening and the rest of the week. Take care.
Happy Christmas, everyone. I don't think it's too early.
Yeah. Happy holidays, everyone. Take care.